Hi, my name is Usama Naga. We'll start a new section, Neonatology Part 1. Two important topics we'll discuss in this section, neonatal sepsis and hyperbilirubinemia. You can follow with me in the Pediatric Board Study Guide Neonatology chapter from page 119. We'll start with neonatal sepsis. Assessment of neonatal sepsis started even before birth. Very important to ask if the mother had a proper prenatal care. Ask about GBS status. GBS screening is between 35 and 37 weeks. Rupture of membrane more than 18 hours is significant. Other infectious diseases during pregnancy, RPR status, reactive or non-reactive for syphilis, hepatitis B. Prenatal history is critical for management of neonatal sepsis. Clinical approach to a newborn with suspected sepsis started with a maternal history, neonatal history, proper and detailed physical examination and laboratory values. Maternal risk factors that can cause neonatal sepsis. You need to know the onset of premature labor and delivery, prolonged rupture of membrane, especially if it's more than 18 hours. This is a risk factor. Maternal chorioamnionitis. How would you know maternal chorioamnionitis? Maternal fever, fetal tachycardia, purulent or foul-smelling amniotic fluid, or vaginal discharge. If you attended delivery for maternal choreo, you will never forget the smell. Urinary tenderness, maternal leukocytosis. Manipulative operative delivery, maternal GBS colonization. Of course, combination of more than one risk factor will make it even worse. Neonatal risk factors: perinatal asphyxia, low birth weight, prematurity, invasive procedures like central umbilical catheterization, presence of open congenital anomalies, for example, omphalocele or gastrus cases. Manifestations of neonatal sepsis. Any newborn presents with any of these symptoms has to be taken seriously. Respiratory distress, for example, tachypnea, retraction, grunting, moaning. Cardiovascular, poor perfusion, tachycardia, bradycardia, even worse, hypotension, shock. CNS like seizures, lethargy, decreased activity, hypotonia. Gastrointestinal, poor feeding, spitting, emesis, bilious emesis, abdominal distension, ileus. Skin pallor, poor perfusion, petechiae, purpura. Metabolic, for example, hypoglycemia. Hypoglycemia is a very important manifestation of neonatal sepsis. Hyperglycemia also can be a manifestation of neonatal sepsis. Metabolic acidosis. Also, jaundice can be a manifestation of neonatal sepsis. Understanding laboratory values is very important in the assessment of neonatal sepsis. White blood cell count more than 30,000 or leukocytosis can be seen in cases of neonatal sepsis. However, can be seen in normal newborn because of stress of delivery or other factors. White blood cell count less than 5,000 or neutropenia can be seen in cases of severe sepsis. Also can be seen in cases with history of preeclampsia. IT ratio more than 0.2 is suggestive, is very sensitive and specific for neonatal sepsis. And this is the immature cells like bands. Divide by bands plus polymorph nuclear cells. This will give you the ratio. So if you see that or you have this ratio more than 0.2, you have to rule out sepsis. Any newborn with thrombocytopenia, platelet count less than 100,000, you have to rule out sepsis. This can be associated with bacteremia, can be associated with DIC. Very important to know early sepsis, you can have all these values are normal. So normal labs do not rule out sepsis. So it means that you have to use in conjunction with other signs. So if you have a newborn, for example, with poor feeding and hypoglycemia, for example, or temperature instability, you have to rule out sepsis even if all these labs are normal. CRP or C-reactive protein, it is a non-specific lab, very important we use in the assessment and guiding therapy in cases of neonatal sepsis. It is commonly elevated in cases of inflammation and bacterial infection. Bacterial infection will stimulate macrophage and T cells. This will stimulate IL-6 and IL-6 will release the CRP from the liver or this protein from the liver and will be expressed on dead and dying cells, and this will activate complement system to clear bacteria from the body. So it is commonly associated with neonatal sepsis. It takes about 12 hours from the onset of sepsis for CRP to rise and 2 to 7 days to go back to normal after successful treatment. So if you are treating a newborn or neonate and the CRP remains elevated or rise after initial treatment, you have to consider resistant bacteria, fungal infection, endocarditis, contaminated catheter. Very important to re-evaluate. Very important to know that normal CRP does not rule out sepsis, can be just early sepsis, because it takes about 12 hours for CRP to rise. So normal CRP does not rule out sepsis. You have to use in conjunction with other signs. Sepsis workup for neonates with suspected sepsis. Initial CBC at the time of admission, blood cultures time 2, lumbar puncture if clinically indicated, if index of suspicion of meningitis is high, or if the initial blood culture is positive. So lumbar puncture is a must in this case, because this will direct the length of therapy with antibiotics. CBC and CRP at 24 and 48 hours, chest x-ray if respiratory symptoms, KOB or abdominal x-ray if GI symptoms, UA. If more than 72 hours onset sepsis, UA has to be either cath or suprapubic. Bag is not acceptable. All newborn with suspected sepsis, they have to receive IV antibiotics. Early onset sepsis, the most common combination we use is ampicillin and gentamicin, AMP/GEN. In cases of meningitis, cefotaxime and ampicillin. In cases of late onset sepsis, you can use vancomycin and tobramycin. Meningitis, ampicillin, cefotaxime. Cefotaxime and ampicillin, very important combination used in the first 2 months of life in cases of meningitis. Necrotizing enterocolitis, you need to use ampicillin, gentamicin, metronidazole, also vanco can be used. When to stop antibiotics? If the baby condition is good and negative indices, means all workup is negative, like cases for example of maternal choreo, and you started antibiotic. If everything is negative, baby is doing well, you stop after 48 hours if all sepsis workup is negative. But if sepsis is strongly suspected despite negative blood culture at 48 hours, you need to continue antibiotics at least for 5 more days of total 7 days. This is very important to know. If there is no meningitis and a proven GBS bacteremia with clear CSF, means no meningitis, the course of antibiotic will be for 10 days. Proven gram-negative bacteremia with clear CSF or no meningitis, the antibiotic therapy will be for 10 days. If there is a meningitis, the treatment or the length of therapy is different, is longer. Treat for 14 days for GBS and for 21 days for gram-negative bacteria. If we are using medications with potential toxicity, we have to monitor the level to prevent auto and nephrotoxicity, like in cases of gentamicin or vancomycin. We have 2 levels here to understand trough and peak. Trough is the lowest point of the curve. Trough is the lowest effective dose of the medicine. So if you are trying to measure the trough, you need to do it 30 minutes before the second or third dose is given, or before the dose is given, in order to have the trough level. If you do the trough level for gentamicin, the trough level, for example, came back elevated, like more than 2 microgram per ml. This is toxic, so you need to stop the medicine until you reach non-toxic level. And how to manage that? By prolonging the interval. Like if you are giving the medicine every 24 hours, you do it every 36 or every 48 hours, or you decrease the dose. So you do not give the next dose until you reach the non-toxic level. For the peak is used only in few circumstances. If you have the ID of the organism. If there is no ID of the organism, there is no need to do the peak. And when you do the peak, you need to do it 30 minutes after the dose is given. This is very important to prevent auto and nephrotoxicity. In the next 2 slides, we'll explain the 2010 CDC algorithm for secondary prevention of early onset group B streptococcal disease among newborns. If you have a newborn with signs of neonatal sepsis, you have to do full diagnostic evaluation, means blood culture, CBC with differential, chest x-ray, lumbar puncture is indicated, and the newborn is stable enough to tolerate the procedure, and you start the antibiotic therapy to cover for gram-positive and gram-negative bacteria, commonly AMP/GEN. If no signs of neonatal sepsis, ask about maternal choreo. If it's positive, you do limited evaluation. Limited evaluation means blood culture after birth and CBC 6 to 12 hours after birth. And you start the antibiotic therapy for at least 48 hours. If all indices are negative, you stop the antibiotic. If no maternal choreo, ask about GBS status. GBS prophylaxis indicated for mother if is no routine care. If is yes, you need to ask about the antibiotic and when the antibiotic was given. So mother received IV penicillin, ampicillin or cefazolin for more than or equal 4 hours before delivery. If is yes, observation for at least 48 hours. If is no, ask about if the baby is full term and the length of rupture of membrane. If it's more than or equal 37 weeks and duration of rupture of membrane less than 18 hours, if it's yes, observation for at least 48 hours. If it's no, either the baby is preterm, like less than 37 weeks, or the duration of rupture of membrane more than or equal 18 hours. If it's yes, you do limited evaluation. Again, means blood culture after birth and CBC with differential 6 to 12 hours after birth, and observation for at least 48 hours, and no antibiotic. You will do antibiotic if you see any abnormal indices. Management of jaundice according to recommendations of American Academy of Pediatrics. This is based on an article published in Pediatrics in Review in 2011. Evaluation for hyperbilirubinemia should occur before birth and extend through the first few postnatal weeks by taking a good prenatal history, knowing the blood type of the mother and RH status for the risk of ABO incompatibility and RH incompatibility. Assessment of jaundice is started even before birth. We have to know the blood type of the mother and RH status, if it's RH negative or positive. Routinely now all pregnant women, they are screened for blood type and RH. If the mother's blood type is O or RH negative, we have to test the baby with COMS test, blood type and RH determination. If the mother is RH negative and the father is RH positive, there is a potential the baby will sensitize the mother, and this can cause hemolytic disease of newborn, and the severity increased with subsequent pregnancies. And now routinely all OBGYN, they give Rogam to RH negative moms at 28 weeks to prevent this disastrous complications. If the mother's blood type is O, there is a potential the mother will pass antibodies to the baby. The antibodies with O is IgG, and IgG will pass through the placenta and will fight the baby's blood. And if the mother's blood is A or B, the antibodies will be IgM and will not pass to the placenta. So this is almost exclusively occurred with mother's blood type O. And this can cause ABO incompatibility, jaundice, and hemolysis. And very important to know that this risk is at each pregnancy the same, is not increased with subsequent pregnancy as in cases of RH negative moms. Once the baby is born, we have to start the assessment of jaundice by asking about prenatal history, blood type of the mother, RH status negative or positive, and risk of ABO incompatibility. When we assess the baby, we look at the color of the skin, the color of the eyes, but routinely now we use J-meter for jaundice. So routinely now in our nursery we use the J-meter every 8 to 12 hours and one time before discharge. So visual assessment of progression, if the baby is having jaundice, visual assessment of progression of jaundice is not reliable. Why? Because many factors, the color of the skin varies from one person to another, especially in late preterm 35 to 38 weeks gestation. This is the statement of Subcommittee of American Academy of Pediatrics. Methods of assessment of jaundice, reliable methods is J-meter or total serum bilirubin. Our goal always before discharging a baby from newborn nursery is a prevention of severe hyperbilirubinemia or severe jaundice. We have to ensure the mother understanding the proper technique of breastfeeding. Very important to encourage the mother to feed more frequent breastfeeding in the first few days of life. 8 to 12 times at least in the first few days of life after birth. This will help to bring more milk and decrease the severity of hyperbilirubinemia. Mothers should be asked about any difficulties. If you have a lactation consult to teach the mom, this will be very helpful. It is recommended now to do total serum bili or transcutaneous bili or J-meter on all newborns before discharge. If you are discharging a baby less than 24 hours, the follow-up recommended to be within 3 days. If you are discharging a baby between 24 and 48 hours, the follow-up within 4 days. And between 48 and 72 hours, the follow-up will be within 5 days. To assess for jaundice, weight gain, stool pattern, voiding pattern, adequacy of oral intake. The best way to assess for adequate oral intake is urine output. Breastfeeding jaundice or early onset breastfeeding jaundice. It is the most common cause of unconjugated hyperbilirubinemia. It is simply because inadequate breastfeeding. Breastfeeding in the first week, you have a small volume. This will cause caloric deprivation and will increase the enterohepatic circulation and will exacerbate and exaggerate the jaundice. The opposite occurs if the mom is properly breastfeeding, the more milk here, and this will decrease the enterohepatic circulation and will decrease the jaundice. Management of breastfeeding jaundice ensures successful breastfeeding by assessment of urine output and stool output. At day number 4, you should have at least 4 wet diapers per day and 4 stooling per day. At day number 10, you should have at least 8 to 10 wet diapers per day. Very important to know that urine output is the most important factor, as stooling may vary from one baby to another. Encourage the mother to breastfeed more frequent in the first few days of life, as we mentioned. Check the weight gain. Normally, babies may lose weight in the first 10 days of life. This is normal. But weight loss should not be more than 10% of their body weight by 3rd or 4th postnatal day. If this occurs more than 10%, this need to be assessed. So it's not normal. So formula supplementation is acceptable in certain situations. If significant weight loss, more than 10%, poor urine output, poor caloric intake, or delayed stooling. Human milk jaundice or late onset human milk jaundice usually occurs between 6 and 14 days after birth and may persist 1 to 3 months. The mechanism is not entirely clear, but it is believed because of certain enzymes in the milk that inhibit conjugation of bilirubin in liver, for example beta-glucuronidase. Management of human milk jaundice. From the name, breastfeeding can be discontinued for 48 hours to observe if the total serum bilirubin is decreasing, and especially if you see the total serum bilirubin is heading towards 20, which is very high. Mother should continue to express milk during this time and supplement with formula. Total serum bilirubin usually peaks between 12 and 20 mg per deciliter and should decrease while you are stopping or discontinuing the breastfeeding to 3 mg per deciliter per day. If this decrease occurs and you are towards the safe level, you can resume breastfeeding again. Let's take a break with some clinical case scenarios. Let's understand the nomogram first. This is the x-axis is the age of the baby from birth until 7 days, and the y-axis is the total serum bilirubin from 0 to 25. Then we have 3 curves to understand. The higher risk curve, and the dashed one here is the medium risk, and the upper one or uppermost one is the lower risk curve. The lowest one we use for infants at higher risk, like 35 to 37 weeks plus 1 risk factor. Medium curve, we use it for medium risk if the infant is more than 38 weeks or equal 38 weeks plus risk factor. The higher one or the highest one is lower risk if the infant is more than or equal 38 weeks and well with no risk factor. Also, you can use the medium one in case of late preterm 35 to 37 weeks but well with no risk factor. So in this case here you have a 24-hour old, 35 weeks gestation, and ABO incompatibility. This is a risk factor, and the total serum bilirubin is 8.2 mg per deciliter. So how would you do that? So you here is 24-hour, then 8.2, so this is 5, 6, 7, 8.2, so is here. So is above the lowest line. Why we choose this line is because the baby is 35 weeks gestation. This is 35 weeks gestation plus 1 risk factor. So you can just always read it in the bottom here. So we use the lowest risk, so is above. So we have to start phototherapy. Risk factors, for example, isoimmune hemolytic diseases like ABO incompatibility, G6PD, significant lethargy, temperature instability, sepsis, acidosis, low albumin if measured. This is another clinical case scenario, 24-hour old, 39 weeks gestation with no risk factor. We have to determine which one would we use. We will use the highest one. Why? Because 39 weeks is more than 38 weeks and well, no risk factors. And the level is 10.8. So this is 24 hours, and 10.8, this is 10, so it's just below 11, so it's here, so it's below the therapeutic level. So no phototherapy at this time, but close follow-up is very important because approaching the therapeutic point. Last case, this is a 48-hour old, 38 weeks gestation, temperature instability, and the total serum bilirubin is 14 mg per deciliter. Which one would we use? we'll use the middle one. Why the middle one? Because this is a medium risk. Why medium risk? Because it's 38 weeks plus 1 risk factor. 38 weeks plus 1 risk factor. So we'll use the medium one. So this is 48 hours. This is 48 hours. And the level is 14. This is 10. And this is the 14. So here is above the level. Start phototherapy. Once phototherapy is indicated, it has to be started as we mentioned in the previous 3 examples. Phototherapy converts bilirubin to water-soluble lumorubin, and this will be excreted in the urine or bile without requiring conjugation in the liver. We have 3 examples here of units used for delivery of phototherapy. A special below fluorescent light, and this is the most effective, but sometimes can interfere with vision, especially if you are using around other babies. Tungsten halogen lamps, like this is the example of tungsten halogen lamps, but you have to follow the manufacturer specification for the safe distance between the light and the baby. Fibro optic blanket can be placed under the baby. The most effective light is wavelength, to deliver wavelength between 460 and 490 to penetrate the tissue to break down the bilirubin. Very important to know that bassinet, this is a bassinet, is preferred over incubators for maximum exposure, unless if incubators are indicated for any other reason, for example temperature instability, prematurity. So phototherapy by itself or simple hyperbilirubinemia, not complicated, is not an indication to admit to NICU. Simply baby can be managed by or close by the mom in the mom's room. This is very important to know. If you start phototherapy, you should expect to see decline in the total serum bilirubin. You have to know that intensive phototherapy, like 3 headlights for example, will decrease the total serum bilirubin by 0.5 milligram per deciliter per hour in the first 4 to 8 hours. Very important to know that. If you see that the total serum bilirubin does not decline or rise during phototherapy, you know that there is ongoing hemolysis. This is very likely. In this case, you have to investigate. You have to be ready for exchange transfusion. In this case, baby has to be transferred to NICU immediately if it's not already in NICU. Very important to know that you cannot use J meter once the phototherapy is started. It's not reliable anymore. When to stop phototherapy? There is no standard, but it is suggested once the bilirubin decreases 4 to 5 milligram per deciliter, or if total serum bilirubin decreased to 13 to 14 milligram per deciliter, you can turn off the light and stop phototherapy. Is IV fluid indicated for treatment of jaundice? The answer is no. Hyperbilirubinemia is not an indication for IV fluids unless the infant is dehydrated. Intravenous fluids should be started in this case. Oral nutrition is much better, is sufficient for infant who is not dehydrated. Supplementing breastfeeding with formula is an option to reduce enterohepatic circulation and decrease total serum bilirubin faster. Common misconceptions about phototherapy: that discontinuation of phototherapy results in a rebound hyperbilirubinemia. This is not true. Some bath or treatment is not recommended. Why? Because it is difficult to determine a time frame that is safe to expose a naked infant to sunlight without getting sunburn. Do not use sun for treatment of jaundice. If you have an infant in phototherapy and you see the jaundice is progressive, total serum bilirubin is rising and not declining, you have to consider serious causes of hyperbilirubinemia. For example, ABO incompatibility, RH incompatibility, G6PD, spherocytosis, elliptocytosis, hypothyroidism, cephalhematoma, excessive bruising, sepsis, polycythemia, infant of diabetic mother, etc. So history and physical examination will narrow your differential. CBC will help you with diagnosis of sepsis, will help you also with types of anemia. Peripheral smear will show you, for example, spherocytes. Reticulocyte count will be elevated in cases of hemolytic anemias. Direct bilirubin will be elevated in cases of biliary obstruction like biliary atresia, Dubin-Johnson syndrome, and colorectal cyst, for example. And UA will be also helpful if you suspect sepsis. TSH will be elevated in cases of hypothyroidism. So in this case, you have to transfer the baby to NICU if it's not already NICU, and you have to be standby for possible exchange transfusion. Exchange transfusion is a medical emergency. You have to admit directly to NICU, bypassing the emergency department. Speak immediately to the neonatologist. Exchange transfusion if jaundice the infant demonstrating signs of acute bilirubin encephalopathy, even if the total bilirubin is declining. or if the total serum bilirubin is more than or equal 5 mg per deciliter above the lines on the exchange transfusion curve. So you have to follow the guideline of that. Or hypertonia, like signs of acute bilirubin encephalopathy, hypertonia, arching, retrocolis, obstetinus, fever, high-pitched cry. This is very important to know. Our goal always to prevent this disastrous complication, kernicterus or acute bilirubin encephalopathy. Dangerous levels of total serum bilirubin or acute bilirubin toxicity. If you have a term infant with no signs of hemolysis, if the level is more than 25 mg per deciliter, this is toxic. If you have a term infant with hemolysis and the level is more than 20 mg per deciliter, this is toxic. Prevention is the key. Management of preterm infants with jaundice. There is no known guideline for preterm infants less than 35 weeks. Even kernicterus is extremely uncommon in preterm infants but can occur with total serum bilirubin as low as 10 to 14 mg per deciliter, so has to be managed very early. Suggested value for phototherapy in preterm infants, you will use the weight of the infant. For example, if the infant weight is 1000 gram or 1250 grams, the value is 12 to 14 in uncomplicated cases. This is a suggested value for exchange transfusion. So you have to use 50% of this value, 50 to 75% of these values. The lower the better. Or you can use another method. You just ignore these two numbers here and use 10 and divide by 2 will be 5. So you start at 5. Here is 12, you start at 6. At 6. If the total serum bilirubin 6 for this infant, you start. If it's complicated, you use a lower value or follow the protocol of your NICU. This is the end of this presentation. Thank you for listening. This video is only for educational purpose and not intended to direct the care of any specific patient. Please consult your physician or the physician of your child for the correct diagnosis and the proper treatment. None of my videos can be superior or an alternative for the opinion of an experienced and licensed healthcare professional. Thank you again.